It's our pleasure today to welcome Dr. Michael LaRiviere from University of Pennsylvania, where he is an assistant professor in radiation oncology. He also works in the Children's Hospital of Philadelphia. Welcome, Dr. Michael.
Thank you.
Dr. Michael, it's our pleasure to have you today in our podcast, Photon, and welcome to Kuwait, and thank you for participating in the MIFOM conference that is being held here in Kuwait for the medical physics.
Thank you so much for the invitation. It's wonderful to be here.
Yeah, thank you for coming all the way from UPenn.
I'm always happy to.
Thank you. Dr. Michael, your focus is mostly on lymphoma, leukemia, for adults and pediatrics, if I'm not mistaken.
That's right.
Yeah, and we know that in UPenn you use proton therapy, and we have a lot of questions about what is the difference when using proton versus photon. So can you just elaborate on that?
So the main difference, proton versus photon, is unlike photons, where the beam goes through the patient and exits, protons come in and stop. So we think about it as just another tool in the toolbox, different ways we can treat our patients. And as you know, with photons, you can treat in a very simple way with one beam or two beams, or in a very complex way with beams coming from all around the patients with volumetric modulated arc therapy, for instance. Likewise with protons, we can create complex shapes and things like that. And so when we're seeing patients in clinic, we're really thinking about, out of all the tools we have here, which one's going to be best for this patient? And in some cases, the answer is proton.
Sometimes. So can you just tell us a little bit about the history of proton therapy and use clinically, and when did it start in UPenn, and how many machines you have, how many gantries, and how many patients do you actually treat?
Yeah, so protons, believe it or not, the first clinical use experimentally was as far back as the 40s or 50s.
Yeah.
But it started to really take off clinically in the 90s. And UPenn opened its proton center in the 2010s. And now it's the busiest proton center in the world.
Yeah.
We treat over 100 patients with protons per day. And we've actually got our main center, and we have two additional centers, one in New Jersey and one in Lancaster, Pennsylvania. And we've actually got even more coming online soon. I think we'll have we're planning for a total of 6 centers over the coming years.
Oh, wow. And what is the qualifications that someone needs? Like sometimes people say, okay, if I work in proton therapy, do I need different qualifications? Can I be a radiation oncologist trained in photon and just switch to proton? I mean, I'm not talking about physics, but mostly from the clinical side.
People who have an interest in treating patients with proton therapy, either from the physics or the clinical side, usually take additional training with proton therapy. And our center is actually one of the biggest trainers of proton therapy clinicians and physicists in the world. So we have a lot of clinicians and physicists actually spend some time at our center specifically for proton education. And then when they go back home, they boot this up at home as well.
So did you go through this training, or where did you start your training to become a radiation oncologist?
I did my residency at University of Pennsylvania, so this proton training is really built into the entire residency program. So for in the US, the way the residencies work are that for a few months at a time, we go through different disease sites. So we might do CNS, brain, head and neck, breast cancer, et cetera. And in each of those sites, for every patient that we see, we would think about, do we think protons or conventional radiotherapy are better? And for the patients who had proton treatments, we effectively got our training on the job over that 5-year residency.
Good, good. And from like the 100 patients you treat per day, you said?
Not just me,
not
but
you,
in the
your team at UPenn. The team at UPenn, so they treat 100 patients per day, right?
That's what I'm told.
That's what you're told, okay.
I think the number is about 200 a day, proton, photon.
Wow.
And then I think about half of those are proton.
That's a lot.
So give or take, and then the volume fluctuates over time, but I think it's about 100.
Do you know like approximately how much of them are pediatrics, how much of them are adults?
So our administrative people could tell you the exact figure, but I want to say it's something like about a quarter of them are pediatric. And again, the physicians who treat pediatric are myself, my partner. She and I treat most of the pediatrics, and then we have another partner who treats periodically some pediatric cases. But the remainder are really other things head to toe. So CNS patients, adult patients with brain tumors. We have patients with GI cancers like esophageal cancer, anal cancer, selected patients with GU or breast cancers. Most patients with breast cancer we treat with 3D photons. And really anything you can think of, ipsilateral head and neck, and then a lot of reirradiation. So we see a lot of patients, probably a disproportionate number of patients for reirradiation, specifically because we can generate more advantageous plans for them with protons. And so I think a good component of patients we have on treatment at any time are reirradiation patients.
So what do you think now is the latest developments with the proton therapy? I remember, starting in the radiotherapy field, they told us, the proton therapy is so big, it needs so much effort, so much resources, and you can only treat pediatrics, but I don't think this is the case now.
I think the biggest clinical development that we have in practice currently, I think, is the use of pencil beam scanning. And pencil beam scanning is where you have individual proton beamlets where you can kind of paint the tumor in 3D. And it's much more focused than the prior proton technology. So as of about 5 years ago, we switched all of our machines over to this. And I think most modern proton machines treat in this way. It delivers much more focused plans than the older passive scatter or double scatter technology. And it seems to have lower side effects associated with it too. I think the things that are on the horizon that I'm most excited about, proton arc therapy is an active area of research where, kind of like photon VMAT, where the machine moves in an arc around the patient, we're looking at proton machines kind of creating a partial arc, which may be able to generate more shapes than conventional proton therapy can. Then I think the most exciting thing that's on a more distant horizon is flash radiotherapy. So conformal proton flash radiotherapy is ultra high dose radiotherapy, where kind of how fast the radiation comes out of the machine is orders of magnitude faster. So the idea would be like what would normally take 6 weeks of treatment, 5 days a week, you could deliver in under a minute. And based on animal models, it seems like this still kills tumor cells, but is safer for the surrounding tissue. So University of Cincinnati just finished their first clinical trial exploring the feasibility of this for bone metastases, trading 8 gray times 1 with shoot-through flash. So it's not,
is it 8 and 1?
8 and 1, yep. And this was for peripheral bone mets. They used shoot-through flash, so it was proton, but it didn't exploit the fact that the proton stopped. And that showed good feasibility and safety. So University of Cincinnati has their second trial now, and they're treating bone metastases in more sensitive locations like the chest. And then University of Pennsylvania will have, I think, one of the biggest tests of flash proton therapy in adults with recurrent head and neck cancer.
With flash?
With flash, undergoing reirradiation. This will be conformal proton flash. And that's run by my colleagues in the head and neck group, and it should open, I think, about this time next year.
Great. I'm actually very, very excited for flash.
Me too.
I think it will change radiotherapy for good. I think it's going to work. Some people say no, but I think I have good hopes.
Me too. I think we're being appropriately very cautious. Where I think the pace of clinical trials is starting with things that are likely to work and unlikely to harm, and I think slowly moving to more and more complex things. So for instance, all of these trials we've talked about so far are in adults, but my group has started planning for a first in pediatric clinical trial in a few years, at minimum, once we have enough data from adults to show that it's safe. And if that data does show that it's safe, then it will start by exploring bone metastases in children.
Is it bone metastases or like sarcomas you would be more interested in?
So long term, I'd be much more interested in sarcomas. We just start with bone metastases because it's so simple and low risk. We have preclinical work in mice ongoing exploring CAR T therapy, an mRNA GD2 CAR T plus flash radiotherapy for diffuse midline glioma. So for us, we really want to bring this to pediatric brain tumors at some point, but I think we're many, many years off from that. But I'm with you. I think that it will work. I think the animal data are so compelling, and the safety data in humans so far are encouraging.
Just one question. Because I'm a physicist, so what is CAR T?
Oh, I'm sorry.
And also the audience are all probably physics or like general, or just like, what is CAR T? Is it a new car from?
So CAR T stands for chimeric antigen receptor T cell therapy. So UPenn developed the first it's basically a special cellular therapy for cancer, and UPenn developed the first use of this that was FDA approved.
Yeah.
The way it works is you remove blood from a patient,
Yeah.
and you isolate components of the immune system, the lymphocytes. And once you have these lymphocytes isolated, they're re-engineered. There's various ways to do this. Re-engineered to target a specific tumor target. So the first one that was FDA approved targeted CD19, which is expressed on B-cell lymphoma cells and B leukemias.
Yes.
We use this a lot in my adult group, treating patients with B-cell lymphomas. And so it's had really remarkable results in children with leukemias and adults with lymphomas. And we've been finding advantages to adding radiotherapy to CAR T. So if we use radiotherapy before CAR T, in adults and people, we've just seen that it seems to make the CAR T work better and have lower toxicity. We've also seen that if the CAR T works pretty well, but there's still some site of disease, then we can target that site of disease with radiotherapy.
And you think flash will be good in these cases?
Yeah, so my partners at CHOP have this CAR T product. It's an experimental CAR T product that doesn't target CD19, but it targets a receptor that's present on some pediatric tumors called GD2. And we think that by adding radiotherapy to this, it will make the CAR T work better. And we think that by using flash radiotherapy rather than conventional radiotherapy, it will make it better and safer all around. So that's currently in mouse experiments right now. But so far the early data seem promising.
Yeah, I agree. So what, from your practice and from your knowledge, what are the most common cancers for pediatrics?
So the main things that I treat are CNS tumors, like brain tumors and spinal tumors, and then lymphomas and leukemias. Leukemias are very common in children, but thankfully these days they're mostly treated with chemotherapy that works very well. My partner treats more of the solid tumors, things that can occur anywhere in the body, like sarcomas or neuroblastoma around the adrenal gland or other neural crest cells. But I mainly do in kids. I think the majority of my patients I see in pediatrics are kids with brain tumors. And thankfully in kids, brain tumors are often much more curable than brain tumors that arise in adults.
And you treat most of them with proton therapy.
Yes.
We still have a big proportion, or a big portion actually, from in the field of radiation oncology and radiotherapy that don't believe in proton therapy. They don't think it's cost effective. They don't think it's needed. They think it's just the hype. What do you say to that?
So I think it's a reasonable point of view. I think what we really need are long-term data and randomized controlled trials. And thankfully, in many adult cancers, we have ongoing randomized controlled trials, and we're going to have more data that come out for adult cancers to tell us if there's a toxicity benefit with protons. And I expect that some of those trials will be positive, some will be negative, but I think it will give us answers specifically with high-quality data. Where is there an advantage with protons? I think the problem is in cancer sites where we're not going to have randomized controlled trials. And unfortunately, those are the things that I treat. So things like Hodgkin lymphoma. The follow-up that we would need to see if there's a benefit would end up being several decades at minimum. And then for pediatric cases, the feeling is so strong based on the dosimetry that we see on the computer and the retrospective data we have so far, that there's such an advantage to protons that I think many pediatric oncologists wouldn't find it ethical to do a randomized controlled trial that tests protons versus photons. So it's unfortunate because in medicine, we want randomized controlled trials for everything. But I think in pediatrics, it's gotten to the point where the retrospective data is so strong that many of us feel that it just wouldn't be ethical to run one of those clinical trials.
But when it comes to adults, why did it take so long to get any clinical randomized trials?
That's a great question.
Thank you.
I don't know the answer to that question. I think I'm totally guessing here.
It's just a chat. We're just guessing.
I suspect that part of it has been we needed to get to a point in the U.S. where there was a critical mass of proton centers and patients getting treated with protons to have enough patients to actually execute a big randomized controlled trial. And I think that we're coming to the point now where some of those trials are starting to read out, but some of them are still ongoing. I don't know if that's actually why, but that's my guess.
Probably. And just an idea, I mean, not an idea, but do we need the clinical trials? Because when it comes to technology and when it comes to the radiation, we can see that now we use VMAT for everything, right? We didn't ask for any clinical trials for that. I mean, do we really need it? I mean, it's not totally a different modality of treatment.
Yeah, it's, I guess it depends. It's a philosophical question.
Yes.
You know, do you view it as an incremental improvement in technology,
Yeah.
or do you view it as a different treatment?
Mm-hmm.
And I think, I think that if everything just cost the same,
Yeah.
then we would probably just be moving to protons in the same way that we moved to VMAT.
Mm-hmm.
But one example in the U.S. at least is in the U.S., for instance, we don't use VMAT very much for breast cancer treatment.
Mm-hmm.
It's mainly 3D, even though, as we saw today, there are advantages in terms of cosmetic and dermatologic outcomes with
Yeah.
VMAT for breast.
Yeah.
And it kind of comes down to the fact that insurance companies don't want to pay for this more expensive treatment versus 3D.
Mm-hmm.
I think it's something similar with proton, where
Yeah.
because it costs more, I think payers are demanding randomized data
Yeah.
to support this, which I think is reasonable.
Mm-hmm.
And I think the other side of the coin is, I think for things where the retrospective data is so strong, or the dosimetric data is so
Yes,
strong,
yes.
specifically pediatrics,
Yeah.
that's where we actually see that insurance companies don't require this data. But it's a really good question, because I think there are a lot of things we treat. Like on the slide I put up, most of those bullet points wouldn't really be testable in a
Yeah.
randomized controlled trial
Yeah.
because they're so patient specific. And I think when I talk with insurance companies about that, they usually seem to agree with that line of thinking, which
Yeah.
is this is a very unique situation, and we have this tool that can accomplish this. So I think it's kind of a balance. For the most common indications, if it's possible to do a randomized controlled trial, I'm all
Yeah.
for it. For the very patient-specific situations that are too unique to randomize, I think that moving forward without high-quality data is the best we can do.
Yeah. Where do you think the field of radiation oncology is going in the future?
So, like you, I hope that FLASH totally changes our paradigms of management, and I won't be surprised if that's the case a few decades from now.
Yeah.
I think in the short term, I'm really excited to see how much AI is changing things.
Yeah.
I think we're seeing that it's kind of improving how everybody spends their time, where it's automating the more mundane tasks and letting everybody in the department concentrate on more cognitively demanding things. So like our planning team, our dosimetry team, whereas a few years ago they were spending a lot of time manually drawing organs at risk.
Yeah.
And then our physician team was spending a lot of time reviewing them and drawing other ones and fixing them. AI has taken that over.
Yeah.
And so now our planning team can spend time developing really complicated plans that they may not have had time for a few years ago. And likewise, our physics team has automated so much that they can spend more time on complex, mentally intensive tasks rather than just rote tasks. I think it's also allowing us to do things that we couldn't do just a few years ago.
Yeah.
So this whole improvement in workflow is letting us start patients with treatment a lot faster. And it's letting us do things for palliative intent treatment with much more complex plans than we could have, just because the workflows are so much easier. And I think in a few years, AI will be doing things that we haven't even thought about yet. And I'm really excited to see what it brings.
What do you want AI to do for you as a radiation oncologist? What is your hopes and dreams?
Oh, that's a good question.
Yeah.
I think, so,
If I can talk to insurance
Yeah.
companies for you, maybe?
yeah, please. I think, yeah.
That would be good.
So I think that's one thing. So
Yeah.
I think many doctors are using AI to write letters to insurance companies.
That's good.
And we know insurance companies also use AI to review letters. So now it ends up becoming an AI to AI discussion. For more complex discussions with insurance companies, I definitely want to make sure I do those in person.
Yeah.
I think I will tell you my current dream, because we're currently working on it, which is I want to be able to I want to have a deliverable craniospinal radiation plan within an hour of learning about the patient.
Oh,
So
wow.
the dream to me would be, a neurosurgeon gets a call that a patient has a posterior fossa mass, so a mass in the back of the brain,
Yeah.
and is already thinking that it might be a medulloblastoma. And if they just text me and say, I think this patient has medulloblastoma, I could envision within an hour of that text having a plan ready to deliver. So basically replacing CT simulation, replacing the contouring, the planning with an automated task. And I actually think that with the tools we have today, that already is possible. I think it's a matter of putting those tools together to accomplish that. I think where this would benefit us is, number one, making sure patients start on the timeline that we need, because we know that patients with these tumors need to start radiation quickly. Number two, for patients we're treating from other countries where they have to make travel arrangements and visas and things like that, being able to get started right away, again, on the timeline that we need. And then number three, opening up new things that we can't do that well already, like treating adult patients palliatively with craniospinal irradiation, which we're doing more and more of. Being able to do this right away, I think, would let us help a lot more patients.
Yeah, I totally agree. I hope that happens.
I think it will.
True. Yeah.
I think it will. And I think it will
Soon.
in the not too distant future.
We always ask our guests this question. Do you have any advice for anybody starting in the radiation oncology field?
I think, so first of all, I'm thrilled that people have discovered the field of radiation oncology and the fields related to it, because I think it's the best job in the world. I think we have so much variety day to day. All of us who work in radiation oncology interact with so many other people. I think the main piece of advice is, if you think about all the people that you're really helping, it makes the work really enjoyable, and it makes the tough days easier. And I think it makes you feel like you've really done a good thing at the end of the day.
Well, thank you so much. It was a pleasure to have you on this podcast, and it was a pleasure to have you in Kuwait and with the MIFOM conference.
Thank you so much for inviting me. It was wonderful.
Hopefully we'll see you again in Kuwait.
I'm sure.
Sure. Thank you.
Take care.